It's really a great pleasure today to have this session in conceptual orthopedics, which is being regulated by Professor Graichen and Professor Dimri, which is definitely a very important session that we are beginning, which will go down the memory lane of the students. You see, whatever you learn, you need to assess yourself. And self-assessment is one of the greatest form. And to help you in assessing all this, these multiple choice questions, which need to be introduced, will be of great benefit in continued learning in this app. And I welcome, in addition, to our family, Dr. Yadav, Dipendra Yadav, who is a young man wanting to get into this learning as well as to participate in these discussions. And my welcome to Professor Shantaramji, my great friend, and Professor Gopakumar, and all the faculty members. And now I hand over the baton to Dr. Apur for further continuation of the program.
Before we get going, I'll request, I'll just show you a small PowerPoint which I have made for the session. The significance of every option in MCQ world and how we can arrive to the correct answer. So I have a small presentation which I made. So I just wanted to discuss this law of probability. Most of the questions that are asked in MCQ worlds after post-graduation in orthopedics will either have 4 options or 5 options. And usually we are supposed to select one best answer. This is a rule I've been following whenever I solve a question. Rather than finding out the correct answer, my approach is to select what cannot be an answer. So to just tell you that if I have 5 options and I'm sure one cannot be the answer, I will, number 1, delete it. Now I have 4 options. Out of these 4, if I make a guess, the probability is I can score 25% times. But if I go further, if I'm able to rule out 2 options and I have to make a guess 1 by 3, so automatically my probability goes to 33%. If I'm able to rule out 3 options and I have 2 left, now my probability is 50%. And obviously, if I rule out 4, which is the ideal way of solving any question, I'm going to be 100% correct. Look, you have to understand what I want to say here. My thought is that if you know the answer, always look at all the options. Because in an MCQ world, you do not score for marking the correct answer. You score for marking the best correct answer. And there can be 2 correct answers in a question. The second thing, be careful about the first option. First option is very dangerously planted. So I always follow the rule 5, 4, 3, 2, 1. So I go from down to up. By this, I make sure I see all the options. So these are 2 biggest mistakes. Be sure you have seen all the options. If you're marking the first answer, you should be 100% sure. This is the only thing which I wanted to convey. And welcome to this session. There are a lot of senior teachers in this session to bless all of you and understand how you should approach a question. I will request Dr. Ravinder Dimri sir to carry on with the session, and I welcome once again Professor Sudhir Kumar sir, Professor Shantaram Shetty sir, Professor Gopa Kumar sir, Professor Heiko Graichen to this session. Over to you, Dr. Ravinder Dimri sir. Thank you very much.
So, can you guys see my screen?
Yes, sir.
Excellent. So, welcome all. And I would slightly contradict Apur in the very beginning that our aim is mainly to make you understand the principle of knee replacements so that you are very confident with the answer you're picking up. Obviously, the collateral benefit will be exactly what Apur said. You will able to answer question in the exam. So the aim is to, we got a very senior faculty here who's got a experience of arthroplasty and well published in literature to help us if we are stuck or some fundamentals we don't understand. But the main aim is to for you to understand why you do things the way you do it and what is the reasoning behind that. To begin with, I must say that mainly what we are exploring today is the standard knee replacement, which we do, that is a mechanically aligned knee replacement. So we're not talking about the anatomical or kinematic knee, which we have discussed briefly in the past, but what we're doing is what 90% or more than 90% knee globally done is mechanically alignment knee. So that's what we will be doing. So without wasting much time, I will start with the first questions. Noful, here is your question, and the clock starts now.
Thank you, sir. The question asked here is the extension gap in a total knee replacement is decided upon by the option A is proximal tibial cut mainly. Option B is distal femoral cut mainly. C, we have chamfer cuts. Chamfer cuts, I don't think it is the answer, sir. Then comes the notch cut.
Mm-hmm.
Notch cut also, I don't think should be the answer. Both the distal femoral and posterior condylar cut. Okay, posterior condylar cut, I think it contributes more to a flexion gap, I feel, sir. So I think I should either go with A or B, sir. So distal femoral cut mainly. I would go for option B. Distal femoral cut mainly.
Okay. Okay, that's good. Tell me, how does the proximal tibial cut affect the gap in flexion and extension?
So proximal tibial cut, it mainly contributes to the flexion gap, sir. And somewhat the slope of the tibial cut, I feel it affects the extension gap at times.
Okay, so we will explore that answer of you. Your answer is right, but proximal tibial cut also affect equally flexion and extension gap, and we will explore that further later on. So let's see your answer, which is a distal femoral cut, and let's understand why you said. So this is a distal bit of the femur here. When you cut it, the distal bit, only two things you're deciding. You're deciding the angle of cut, which is 90-degree to mechanical axis, and obviously 5 to 7 degree to anatomical axis, and then the thickness of the cut. at how thick you cut, and this thickness will decide your extension gap. Why the tibia also decide extension gap? Because tibia universally, whether it's flexion and extension, is contributing the same surface articulating, whereas on the femur side, when in extension, the distal bit articulate, and when you flex, the posterior bit articulates. So tibia contribute both for flexion and extension, but it is, if you have to pick one, again, these, as Apur was saying, sometimes very tricky, these questions. And you can see proximal tibia can affect, but if you have to pick one from this choice, a distal femoral cut will be a better choice from me. Let's ask Professor Graichen for his input.
Sir, you have to unmute.
I think the comments were excellent, and also the slides showing it nicely. So on that slide, you see that if you cut the femur distally, that is an extension that is affecting your extension gap. And the more that you flex the knee, then it goes to the posterior cut. And the tibia, as it was mentioned, is affecting both. And that's why answer A is not the right answer. It affects the extension and the flexion gap.
Thank you, sir. Nawfal, let's come to the question number 2. Your clock start now.
Joint line after TK is decided by. Joint line is decided by A, proximal tibial cut, B, distal femoral cut, C is chamfer cuts, both the distal femoral and proximal tibial cut, and E, it depends on how much the surgeon decides to cut. Sir, I've ruled out C option. Chamfer cuts is not the answer.
Mm-hmm.
I would like to rule out option E as well. The surgeon has to be careful to maintain the joint line. The distal femoral as well as proximal tibial. Sir, I would go for option B, sir. Distal femoral cut decides upon the level of the joint line, sir. The more you cut the distal femoral cut, I think the joint line should go higher.
Okay, Nawfal. So just extending the question. So what is your usual distal cut?
So I would like to replace the amount of cut by the implant thickness. So if the implant thickness is 9 mm, I would like to take off 9 mm from the normal side, unaffected side. Sir.
Yeah. Do you think there's a lot of variability in the distal thickness of the implants available?
So universally, I feel most of the implants have a 9 mm this thickness of the distal portion. That's what I feel, sir.
Yes. So why don't think you, because there are two surfaces, the tibial surface and the femoral surface. Why do you think the tibial surface doesn't contribute to the joint line that much?
So the distal femoral cut, I think, like once, like if you cut 10 mm, you will be only able to replace that particular cut by 9 mm thickness of the implant, sir. Whereas in the tibia, like you have various options of inserts. Like if you cut more, you can replace that amount what you have cut with the insert as well as the tibial tracer. So I think that doesn't contribute to the.
Excellent. That's an excellent answer. But can you sometime cut too much distal, and can you replace that?
Too much distal.
Like you can build up the distal cut or tibial cut with the insert. Can you build up too much distal cut with anything?
With a bone graft or an augment, can we do so?
Excellent augment. So not in the primary case, but if you have in some time in the revision, you may have a choice that you have no other option, but distal cut is too much. But then you can build up with the augmentation. But normally, you know that tibia you can keep on building with the tibial insert, whereas distal femoral is normally your 9 mm. So this is your 9 mm cut which you normally go. The posterior thickness can vary sometime in a high flexion, or there are different implant can have, but universally the distal cut is distal thickness of the implant is 9 mm. Even the posterior normally is 9 mm, but that can vary. Distal is not much variation there. And as you can see, you cut your distal femur. If you suppose instead of 9, you cut 11 mm, so your joint line going up, because you will build up that 2 mm loose gap with a 2 mm bigger insert. So your joint line go up. So now, when your joint line go up, what happened to the patella?
So the patellar biomechanics is affected. The
Yep.
patella can come down, slide down.
The patella stays where it is. Yeah. So let's say
The level of the,
patella is stationary there. If the joint line keep going up, compared to that joint line, the patella become lower and lower, and patella baha. Yeah.
yes, sir.
So do you know some ways to assess your joint line during surgery?
So I think you can compare with the level of the patella, sir, the lower pole of the patella.
Yep. Anything else?
Sir, I'm aware of only that, sir.
Okay, so there are few things you need to know. So remember this, as Noful rightly said, if you cut too much, you can build up with the tibial insert, and that's why that joint line will be where it is. Whereas if you cut too much femur, you can't build it up, and so the joint line will keep going higher up, and your patella correspondingly will become baha. And there are certain ways you need to know, some bony landmarks and some soft tissue landmarks. The one is, as you rightly said, the lower pole of the patella. Normally that can be quite variable. We don't use, but we can use the bony landmarks from medial and lateral side. So you got epicondyle on both sides. So you can measure from medial side, it's a little bit higher, 30, 35. And from the lateral side, it's about 20. Or from the tip of the fibula, you can measure about 10 or so. So 10 here, about 20 here, and about 30 here is the joint line we can measure. So these are things you need to know. Obviously, patellar height you can measure separately, and all of you should know these are the questions sometime can ask, how do you measure patellar height? So some radiological reference at about 30, 40 degree flexion, you should know these categories. Back to Professor Graichen, sir.
I think you answered the question very, very correctly. I just want to point out one aspect. So the 9 millimeters of the implant resurface normally the medial condyle. So that is in most of the knees the prominent one. So you don't resurface 9 millimeter medial and lateral. The lateral cut once in a while is less than 9 millimeters. That depends on the mechanical and anatomical axis you cut. So, and if you have in a varus knee, for example, a completely worn out cartilage on the medial side, then you have lost 2 millimeters. If you then cut 9 millimeters, that would raise the joint line by 2 millimeters. So you always have to estimate how much cartilage is lost. And that cartilage then you have to add to what is left. So that means once in a while you cut only 7 millimeters because the entire cartilage is gone. Otherwise, with 9 millimeters in that situation, you already start raising the joint line. And we heard problem of raising the joint line is one of the big issues that we have in primary knee surgery.
Thank you, sir. So to re-emphasize that, can you all guys see, if you see a normal femur, the medial side is much distal than to the lateral side, normally. If you got varus, normally varus is the worn out from tibial side, but sometimes can be femoral side also. So careful. If that is lost, then your reference will be, if you cut then 9, then you're cutting here. And so joint line will be raised. So is that Noful, you understood that?
Yes, sir.
Yeah. So remember, when you're putting your jig, normally it doesn't sit on both. It will sit on medial condyle because that's more distal. Is that okay, Professor Graichen?
Definitely, it's okay, and I don't want to confuse the group with the kinematic alignment guys. They would cut on both sides equal, but keep it to the mechanical alignment, and then in most of the cases, it's more on the medial side than on the lateral side. So look at the most prominent femur.
Yeah, good. Thank you. So remember, guys, the most prominent femur in your proximal distal direction or superior inferior direction is the medial femoral condyle. Most prominent femur, which we'll discuss, probably will come later on, is on the posterior bit, is also the medial side, and we'll discuss that later on. But remember, when you're cutting a distal cut, you're referencing it to the medial condyle, and you have to be careful that it's not worn out too much. Question number 3, Nawfal.
So, tibial cut, sir. So I want to give a 0 degree cut, sir. So I think option C is more suiting, because in A and B they have mentioned about a 5 degree valgus and a 5 degree varus. So that is ruled out. And D is they've told that you have to measure from the eroded portion. So I think the normal side should be assessed, and according to that you should perform your cut. And the last option is should be decided according to a combined valgus of 5 degree. No, sir, I would like to keep a 0 degree cut. My answer will be C, perpendicular to the anatomic axis of the tibia.
Okay, so Nawfal, just tell me, a native knee is what is the proximal tibial alignment or axis of the with the anatomical axis? What is the normal angle? Is it perpendicular?
Sir, it's in some amount of varus.
How much varus?
Around 3 degree approximately.
3 degree varus. And when you're cutting it 90 degree to 90 degree, you are actually not making it what is anatomical. And that, as Professor Graichen was saying, that is a different philosophy altogether, whether you want to mimic a natural anatomy or mechanic. Here we are, for the ease of us, we cutting it 90 degree to mechanical axis. And that is very important thing to understand, that we're not cutting it to what it normal anatomy is. Okay,
Sir.
You understand that?
Yes,
Yeah?
sir. Yes, sir. Yes, sir.
Okay, so we're cutting 90 degree to anatomical axis, and we normally, if you start chasing up the worn out joint, then you can cut it much thicker than required. So always don't try to fill the defect by making your cuts. You make the cut what you want to replace, and then think what you can fill that defect with. So otherwise, again, you will lose too much bone if you cut on the side where there's a more loss. So your answer is right. That's perpendicular to anatomical axis, and you need to remember that most of the knee which we're doing mechanical axis aligned knee. So we're cutting them 90 degree to both tibia and femur. That's our goal. How we achieve that goal is all the jig and helping us. But remember, in normal knee, it is a slightly, the tibia is actually slightly into varus, also about 3 degree, and that's what mechanical alignment or anatomical alignment knee trying to chase that up. So that's Professor Graichen has shown these multiple time, that how that affect and why we're not getting good result with knee replacement as we would expect. 20% knee are still unhappy, and he mentioned maybe we changing a wrong target, but that's a story for some other day. Today, you remember 90 degree to mechanical axis, that's what we want to cut, and in tibia, mechanical and anatomical axis is same. Professor Graichen, you want to add anything to it?
Just maybe a bit on the height. So normally we cut from the lateral side in the varus knee, this 9 millimeters. But once in a while you have very loose knees. So then maybe you reduce your cut on the lateral side just to preserve bone, and on the other side to minimize the insert that will later come into the joint.
Yeah, so important bone preservation is very important. So we do need to cut a minimum to replace the implant width, but make sure that if the knee is too loose, then you don't cut that much, and then you will have to do something to deal with that. So 9 mm is standard from your uninvolved side. Involved side should be minimum possible from here, but if it is worn out, say up to this level, and you chase this cut, then your cut will be somewhere here, and which will be too much, which is not recommended. So not from this side, 9 mm, as the thickness is gone, and we're cutting 90-degree to your anatomical or mechanical axis, which is collinear in case of tibia.